If you could tell me your name and why I might be interviewing you for this documentary.
My name is Dr. Vanessa Britto. I'm a general internist here in Brockton, Massachusetts, which is in southeastern New England. I have an interest in preventive cardiology and have been a volunteer and have had interest in the American Heart Association for a very long time. And I hope that's why you're here, but I particularly have an interest in the whole issue of minority groups and particularly African Americans and cardiovascular disease prevention.
Mm-hmm. I don't want to use any charts or graphs in my documentary because
Sure.
I think people don't really
Sure.
understand it. And this is just for your reference if you want to, or if there's just, if you
Mhm.
want to describe it all, what the problem is, just in terms that people can understand.
As you can imagine, the problem is vast, and it's multifactorial. Certainly from a medical standpoint, you can't avoid thinking about some of the sociologic aspects of the problem, certainly the economic aspects of the problem. They all are intertwined and interface with one another. Certainly when you look at the statistics, all of the risk factors for heart disease, such as hypertension and diabetes and hyperlipidemia or high cholesterol levels and obesity, all of them unfortunately are particularly problematic in the African American community, where the rates are often much higher than they are in majority populations. And we can certainly talk about why some of that is. But all of the graphs and charts that you look at basically give you a visual picture of that disparity. And that's the big problem, and we're trying to close that gap and trying to get the word out to people in ways that are relevant, innovative, creative, and yet poignant, so that people understand the seriousness of the issue.
Mm-hmm. I'm just going to turn this a little bit. Could we talk just briefly so that people can help to understand the scope of this problem?
Mm-hmm.
Can you just give me a second here? Yep, 4:30? That's I
Sure.
figured you might be able to
Sure.
have
Sure.
some of the statistics and numbers handy.
Right.
But it doesn't even have to have numbers attached to it, just because I don't think that people really understand the scope of this.
Mm-hmm. Mm-hmm. Yeah. For example, we think of cardiovascular disease in general as being a serious problem, but every 33 seconds, someone in the United States is dying from some aspect of cardiovascular disease. If you think of the life expectancy that we all have, if you were to eliminate cardiovascular disease as a cause of death, it could increase the life expectancy by 10 years.
Mm-hmm.
And to put it in perspective, if we were to eliminate cancer, and this is not to diminish that public health problem, but if you were to look at the whole issue of cancer and eliminate that, it would raise the life expectancy by 3 years.
Mm-hmm.
So I don't know about you, but I can do a lot in 3 years, but I can do a lot more in 10. Mm-hmm. So there is tremendous room for changing this problem in the minority community.
Mm-hmm.
So I don't know if that gives you some perspective of
Mm-hmm.
of the relationship between, for example, cancer, which everyone is fearful of, and in comparison to cardiovascular disease.
Well, how much more at risk are African Americans for heart attacks, strokes, all of the cardiovascular related deaths?
In 1995, the cardiovascular disease rate for black men was 49% higher. And so for black females, it was 67% higher. 50% or more of all African American women are obese. There are lots of reasons for that. Some of them are social and cultural. images that we all have of ourselves, and whether or not we should conform to society, the wider society's standards. And so people may not place the same importance on rates of obesity or you know, whether or not they're exercising or whether or not they're really watching their blood sugar levels, for example. So it's a huge problem. We can go through each of the risk factors if that's helpful to you, and talk about.
Well, maybe we can just take a step back. 49% higher. It just gives you a number here that's 733. What does that mean if you had, say, 100 people? You know, how if you
Right.
put that in terms that
Right. If you had 100 people, 49 more black males. Say you had a whole room full of black males and a whole room full of white males. 49 more black males would be at risk for dying from a heart attack or heart disease, as opposed to you know, the white male population that you're looking at. And the same would be true for the black female population. So, you know, 49 is a significant number of, that's half, the half of the group.
So maybe even if we made it in terms of you had two groups of 10 people of white males and black males.
Right, five. Half, yeah.
And with women, then it's going to be more like almost 3/4.
Exactly. It's actually, if you had, say you had 10 men, and you had 10 white men, and you had 10 black men, certainly all of the black men would be affected, and an additional group of 10, 5 more would be affected. So it's a 49% higher rate. It's significant. It's significant.
Yeah, because I think until we start talking in terms like that, people talk statistics.
Right.
But when you break it down into, you know, imagine a group of people.
Right.
I think it becomes
Right.
much easier to understand that.
Right. You know, we talk about the whole issue of as I was saying, the whole issue of life expectancy. And people don't really think about the premature nature of heart disease. We get really concerned as healthcare professionals when people, men in particular, start to have symptoms less than the age of 55. That's considered premature. And for women, that's a little bit higher, mostly because of estrogen and other protective risk factors. But you know, it's important to know your family history, and in a lot of cultures and a lot of traditions, people don't talk about it, or people sort of dismiss it. Well, you know, he was 60 years old. Well, 60 years old is not old, and people ought not be dying at 47 from heart disease and stroke. People ought to you know what their risk factors are, and ought to know what their cholesterol levels are. And we know that 50% of people who have diabetes, for example, don't even know they're walking around with it. So that, we know, elevates the risk of heart disease. It accelerates the whole process. So it's vitally important that people understand the difference and how you know what their blood sugar levels are, and particularly if they have a family history of diabetes. It's very important.
One of the things that I've been talking with a lot of people about is that race is primarily a social construct, that it's not really a physical or biological. If that's the case, then where does this come from? Why is it that African Americans, if this is a social construct, what are the connections? Where, you know, how does this happen?
It's a very, very important question, and I think one that sociologists and psychologists, and certainly the medical profession is trying to tease through. I think a lot of it has to do with access. Not having access in certain communities, for example, not having community health centers, and even as healthcare professionals, we probably not probably, we could certainly be a lot more responsive to the communities that we serve. And for example, having office hours that are conducive to people who work, having Saturday hours or having evening hours. When you serve a community that's a working class community that needs to access the healthcare profession, they need to do it at a time that's convenient for them, so that they're not putting themselves at risk, for example, for losing their job because they're taking time off to go to the doctor. So we have to be sensitive to that. There's also in some circles a mistrust of the medical community, and I have to say that there are some traditions that have gone on that have been, quite frankly, a little hostile to underserved communities. Insurance can be a problem. Some people are very reluctant to use the healthcare institutions in their community because they don't have insurance, and so they may be using the emergency room, for example, as their primary care facility, and we all know that that's inappropriate. And so there's no continuity, and there's no one to follow up cholesterol levels, and there's no one to sort of sit down and educate people about proper nutrition and lifestyle changes that are conducive to promoting good cardiovascular health. So I think that the racism that we're beginning to recognize and acknowledge in the healthcare profession is very deeply rooted, and I think it will take many, many studies to really face the reality of the situation. And I think it will take a lot of soul searching for people to really come to terms with it and deal with it the way it should be.
I had my upstairs neighbors who were both doctors down for dinner last week. I think it was Tuesday night. And talked with them about this. They're new neighbors. They just moved in, so it was a little welcome. And they said that they actually have been taught to treat African Americans with different medications, and they're treated differently than European or white Americans. It didn't make sense to me.
Well, you know, again, in some studies that have been done, they have found that some populations have responded. Now we're talking in large measure about, you know, whole populations, but they found that, for example, in hypertension, you know, that African Americans may respond to certain classes of medicines differently than Caucasians. And so traditionally in medical texts, we've been sort of instructed to keep that in mind. Does it mean that it's etched in stone? No, not at all. You still have to look at the individual patient. Those studies were done on again, populations of people, and so those are generalizations. You know, I've heard some very interesting and read some very interesting theories along the way about the underlying cause for hypertension in African Americans perhaps being a little different than that in Caucasians. And so that being a possible explanation for why people respond differently to different medications. One theory is that when you think of African Americans who are here in North America, for the most part, people were indigenous in Africa and perhaps survived the long Middle Passage. When you think about the horror of that whole journey and how many people were sacrificed, you might want to think that those people who survived had some sort of predisposition that allowed them to adapt to that whole environment. One of those adaptations may have been the fact that they were able to hold on to whatever small amount of water they were being given, and in passing that genetic predisposition on, when you're now in an environment where that adaptation is no longer necessary. For example, in a culture where you have a lot of salt, those people who have a lot of salt in their diet, for example, may hold on to that along with the water. It's a whole adaptation that's in the kidney, and so those people, being African Americans, may respond better to, for example, diuretics that release some of the salt in water. And so that may be one of the associations between the disparity or differences in medications that people have suggested be used.
But the thing that's interesting to me about all this is that there's been so much intermarriage. There's been that the people who are here now are so different from their ancestors, just as all of us are.
Right. And that's why I say it's really something that should be. This is all theory, and it's certainly there are certainly theories that were touted a lot more in the past than they are now, and you really have to evaluate people on an individual basis. But that's true. I mean, there's been a lot of admixture. There's been a lot of intermarriage, and so there is no true anything. There's no true anything, which is all the more reason why, we all have to get past some of the disparities that have unfortunately plagued our culture and our healthcare traditions.
The other thing that seems to play into this quite a bit is racism, and the amount of racism that African Americans experience every day. Do you think that plays a part, the stress of having to, because just about everyone I've talked to say that they experience some form of racism just about every day of their life. Can you talk a little bit about that, how that stress, how do you think that must affect or
Absolutely. Stress plays a very important role in all of our lives, and certainly when you're in a social environment that causes you to sort of be on guard much of your time, whether or not you're even aware of it on a conscious level, has some physiological effect on our bodies. There's no question about it. Has it been measured? It probably hasn't been quantitated to the extent that it would be recognized in wide scientific circles. But everybody, I would say that certainly anyone who lives in America in the year 2000 and has gotten to age 15 or 20 or 30 can give you countless numbers of incidents that have been both subtle and overt. So the mind and body are connected, and it would be hard to say that people would not be internalizing some of the stress that they encounter in their workaday lives, in their social lives, in just about everything that they do. How you perceive it and what you do with it is often a different, a different story, and some of that dissociation may be where some people are able to manage the stress better than others, and then what does that mean?
Right.
What does that mean? So. Being able to be calm at work, but going home and, screaming at your kids all night or shutting your family off because you just can't deal, your mind is so exhausted, is certainly not healthy.
Yeah, I've read several interesting studies. Let me give you time here, Sue. 2106. Several interesting studies where they've put African Americans in situations where someone will come in. I mean, it's all a test situation. Someone will come in and treat them just in not very nice way. Sometimes in half of the situations they involve some sort of racial situation, and other times they specifically take the racial slur or whatever it is out of the situation. And actually, the African Americans have higher blood pressure and react more strongly to the situations that don't have the specific racial, intent.
Overtones. Absolutely. Absolutely.
And those have been very interesting.
Yeah.
That I was talking with Camara Jones from the Harvard School of Public Health, and she was saying that for me, I can get into a bus and just assume that the bus driver just may be having a bad day. But for her, she can't. She always has to think that there's some racial overtone.
Right. It sort of goes through a different filter. And I know you've heard that term before. It does. It gets processed through a different filter. And again, what you do with the information that you get on the other side of that filter may play into how your body physiologically deals with it, or how your mind deals with it. But yeah, that filter is there, and I'm not sure we know where it comes from. It's the social construct that we've all been sort of raised in, and I guess that's what the socialization is all about. Maybe someday that filter will either get smaller or non-existent. That would be very nice. And it's certainly, I won't say scary, but there are times when you let your guard down, as it were, and not necessarily feel like you should have your guard up, or you should be, that filter should be in place, and then something happens, and it's like, oh, okay, I remember now. Yeah. My fault. I should have, sort of not left myself vulnerable. I don't want you to think that people walk around in a paranoid state, but it's, as I said, it's there sometimes not even on a conscious level.
I mean, I must assume that, I'm just going to put this up here so I can see without having to look down. I must assume that there just has to be a heightened level of awareness all the time, that it's not something that you have a choice about. So this gets into another aspect of, well, what do you do? Like, what do you do? What are the coping mechanisms that you use?
Professionally, it's a good question. I guess, I have a filter like everyone does. I think that I certainly try to give people the benefit of the doubt, and understand that professionally I know that I'm perhaps walking through doors that haven't been walked through before, and I have to give people an opportunity to make some adjustments in their own thinking, and vice versa. In taking in their response to me or to what I'm doing, I have to give people some leeway to sort of get adjusted to my role, whatever that might be. So, personally, sometimes you try to, sometimes you brush things off, sometimes you look at them with humor. I think that's very important for people to maybe not take everything that happens to them to heart, and understand that there are just some funny things or quirky things that happen in life. And you have to also, I think, use, as we say, teachable moments to convey to people that I may be different from what you expect, but I want you to keep your mind open. I want you to keep this interaction out of a box, so that we can relate as people, and then take it from there. I can give you endless stories. There are things that have happened to me, for example, when I was training in the mid-'80s, where I would walk into a hospital room dressed much like I am now, and have someone look to her husband and say, "Oh, honey, the TV lady's here. Isn't it wonderful?" And my colleagues, we laugh at some of those, but we've all been in that situation where people have sort of made assumptions about who we are and what we're there to do.
Yeah, no, I've heard situations of, with even people who are very known in their field, and even in the education community, just feel that they're not being treated the same way as everyone else.
Right. Yeah, it's, and certainly, we can talk about some of the studies that have been coming out most recently about differential treatment in patients, and how, some patients have been, they've done studies where they've had patients who are in the exact same situations, but been of Caucasian descent, and others have been African American, and they've sort of been led down different pathways of treatment for interesting reasons. So, and again, we don't have a good handle on, or people who've written the studies don't have a good handle on why that is, but it is.
Yeah. If you had a magic wand, if you could change things, what would that vision be?
Maybe for everyone to have an opportunity to get rid of their filters. For everyone to be able to interact without having to think about the social construct of race. That would be utopia. That would be the ideal. I won't see it in my lifetime, but maybe as our society gets smaller, as the world gets smaller, as our roles change sociologically, and I'm hopeful that it will be a goal that we'll be stretching toward, but we'll just have to see.
Mm-hmm. This is great. If we could just backtrack a little bit to the, we're talking again, maybe we can make it a little more clear about the difference, about the statistical difference, just to help people really understand how big a problem this is. If you could, oh yeah, 28, 58, 29. Am I taking up too much of your time?
No, not at all.
Okay.
Actually, today's my administrative day, so
Oh,
I don't have patients to see today. So it's fine.
And again, using it in terms like you were before, if you had 10 people, 10, it just makes it easier to understand that way, because I'm surprised at how many people don't, and both in the African American community as well as in the white community, people don't understand the scope of this problem.
Okay, let's talk about, for example, diabetes. In women that are 20 years and older, let's just use females for an example. 4.5% of white females have diabetes, and 9% of black women have diabetes. That's twice as much. So, for every one person who is Caucasian, 2 women have, if we're looking at women, 2 have diabetes. And there are so many examples like that. You can just imagine. Well, let's see. Another example would be, we talked about obesity.
You can talk about heart problems and high blood pressure again as well.
Okay.
Because that was good with the 1 and the 2.
Yeah. Let's say over 500,000 females every year have heart disease. 1 in 27 women's deaths are associated with breast cancer. 1 in 2 women die of heart disease. As a female, I think we're frightened by the whole notion of breast cancer, but heart disease is so much more prevalent. In the case of hypertension, 34% of black women have hypertension. 19% of white females have hypertension. So again, you can see that the number is much higher in the African American community. So even more than the statistics, I think, is the whole general trend that all of the risk factors that impact on cardiovascular disease and on heart disease are more prevalent in our community. And I think that's the take-home message that people should have. We have work to do. And none of us should shirk our responsibility as healthcare professionals in getting that point across to people, and whatever it takes. Again, sometimes it means being creative in how you get the message across. I know that you spoke with the folks down at in Rhode Island who were working on the Heart to Heart project, but projects like that really bring the message to the folks who really, really need to hear it in a fun way, but in a way that is meaningful, I think is very, very important. You know, we can't stand in our ivory towers and expect people to come to us. We have to go to them. We have to go to where the needs are. And, you know, that means explaining good nutrition to the people who prepare the food. That means demanding in our communities that, you know, we not be targeted for, you know, fast food, for example, or specific cigarette brands, or alcohol in particular. I think that, you know, we have to look at what our media is projecting to our community. You know, it may seem like a way to be mainstream. It may seem like a good way to sort of conform to society or fit in, but you know, wolfing down McDonald's and Burger King is not the answer. It's definitely not the answer. There are other aspects of our wider society that we ought to look at, like building areas in our community where people can walk safely. You know, not everyone has access to a mall. Not everyone has access to a decent gym in their communities. But we all know that exercise is really important. So maybe we ought to think about the role of the church and get people more active in interfacing between the community and the church, and using that as a safe place for people to go and participate in exercise programs or nutrition classes or get educated about diabetes. So I think that there are ways that we can get the message across, and are doing that. I mean, I don't want it to sound as though it's not happening, but I think those efforts should be supported more and encouraged more, and certainly should be more widespread.
Mm-hmm. You have the opportunity to say one thing, to say something. What would it be? I mean, what do you think is the crux of the issue here? Is it racism?
I think that, you know, I think that's part of it. Is it the whole answer? No, it's not. And I think as a community, we all understand the role that plays in our lives in general. So to the extent that it's part of our workaday world, it's part of how we interact with the medical community. But I think that what we need to do is educate ourselves. What we need to do is understand our family histories and understand that we don't have to lose our traditions, we don't have to lose ourselves as a community, but we do have to get healthier, or else we're not going to be here.
That's great. My last question is always, if you were interviewing yourself, would there be a question you'd ask that I haven't gotten to?
Oh, I think that's the hardest question of all. I think you did a great job. Well, no, we talked about, I think, just about everything. We talked about the role that the medical community should play in this, and I think that I can't really stress enough that people in the medical community really have to take some responsibility for the position that we've been given. Because it is a responsible position. We have to step outside the box and walk outside the doors of our emergency rooms and our front lobbies and really stretch our arms out to the communities that we serve. Excuse me. And sometimes, again, that it's amorphous. Sometimes it's hard to put into a box, but I can't really express enough the importance of really taking ownership of at least a portion of this. It's a partnership, and you know, yes, we have the knowledge that we need to disseminate to the community, but we can't stand by and wait for the community to come to us. I think it really has to be a give and take. It really has to be a partnership. We have things that the community needs, the community has things that we need, and I think the partnership needs to be more joined. So I think that would be my only other message would be to just express to the medical community that we have to take ownership of this.
That's great. Unless you have something else to say, I think that was terrific. We give you time, so 38:15.
I don't know if any of that made sense. It was probably all mumble jumble. I feel like sometimes I get bogged down with statistics, and I think I'm probably one of those. You know, there are some people who who look at sort of the big picture, and some people who look at the small picture. And I apologize if I struggled with, sort of looking at the smaller points, but I want to hit my colleagues over the head. Do you know what I mean? Yeah. And if maybe that helped to do that a little bit. I think, groups like the Heart Association need docs to sort of, nurse practitioners and people to sort of step out of the box a little bit and do what they really need to do. Mm-hmm. Get this message out there. So, I don't know. I think this is yours. I don't want to.
That's great.
Keep your stuff.
Great. Roll.
Sure. But for the longest time, I can remember my mom saying things like, we talk about, what happened to someone who passed away. And my mom would say, well, they died of complications. Well, what is that? Mm-hmm. What complications? My husband's family is in the funeral business. Mm-hmm. And he'll talk to his folks at home and say to his dad, well, his dad will say, well, so-and-so and so-and-so passed away. Well, that person's really young. What happened? And my husband's from the stroke belt in Mississippi. And, a person might be 47 years old and had a massive stroke, or 42 and had a massive stroke. Well, what happened? Just died. Yeah. Do you know? So it's important for us to understand our family histories and talk about it. Because when people have genetic predisposition to some sort of problem, you have to intervene that much sooner. This stuff happens not when you're 40 or 50, even though that's when the disease manifests itself. It starts when you're 20 or when you're 10. They've done autopsy studies on people and found that there is evidence of cardiovascular disease in children. So, it's a gruesome way to make the point, but I think that we have to intervene with children and get the point across that, it's never too late, but certainly when you're 15, 16, 70 years old,
right. It's also
it's very difficult to suddenly start exercising if your concept of exercise has been that it's play. I don't have time to play. I work, I take care of my kids, I'm a single mom or I'm a single dad, and I'm trying to do this. And yes, I'm stressed out. My only vice is that I smoke or I drink or I do this or I do that. But those are vices that are gonna kill us, and we have to intervene early. We have to make the changes when people are teens, get them used to exercising so that when they're 40 and 50 and someone suddenly tells them that they've got high blood pressure or their cholesterol is elevated, it's not some new revelation that they suddenly have to make major changes in their lives. Mm-hmm. And that's not easy, in the technological world that we live in. It's so contrary to to that whole notion of getting up and walking across the room. I have a nephew that I love dearly. Several years ago, we moved into our home, and our cable wasn't hooked up. I had a little tiny 9-inch television, and my nephew looked at me and said, "Well, Auntie, how do I change the channel? There's no," it's like you have to get up and walk across the room and change the channel. But, unfortunately, I mean, I don't have to tell you that with all that's going on with video games and the promotion of a sedentary lifestyle, kids aren't moving.
Yeah.
And I think we have a lot of work to do. I mean, it's snowballing, and I'm kind of fearful of what's going to happen to this generation of kids when they're 50 and 60 years old.
Well, it's interesting that you bring up, because that was one of the things that I found that was so interesting about this whole problem. I started talking with people, and oh, my uncle, my aunt, they could list off all the people that died or have cardiovascular disease and all sorts of problems. Then when I say, do you understand how complex and how much of a problem this is in your community, they didn't see it.
Yeah.
And that just seemed like such a...
I think part of it is because it's unfortunate to say, but it's almost become an expectation that, well, my uncle and my dad and my grandfather all died when they were young, so, if I live to be, I can't tell you how many times I've heard, well, if I live to be 60 years old, I'm the oldest male in my family, so I think I've done well. Well, your life expectancy ought to be another 16 years. You shouldn't expect that you're gonna die when you're 62 years old or when you're 57. So, I mean, we can't change our genetic predisposition. I tell patients that all the time. We can't change that. But certainly the things that we're doing to ourselves, like smoking and not exercising, not watching our blood pressure, not watching our blood sugar levels, all those things we really need to take responsibility for. And that's nobody's fault.
Right.
Smoking is certainly one of those things that's my pet peeve. And I have to say that in our community it's not a big thing, but it is there. It is a problem, especially when you go to parts of the stroke belt and further south, tobacco country, where it's just a part of what you do. It's a rite of passage. But there are lots of things. Even talking about diet and what we think about as comfort food. When we think about our favorite Thanksgiving dinner, it has macaroni and cheese and greens with fatback or ham hocks and all kinds of stuff. And and it's fine to do that once a year, but when once a year becomes once a month or every 2 weeks when you visit your mom and she makes this massive meal, it's a problem. So I think we like a lot of cultures sort of associate comfort and tradition with some of those foods, and some of those foods are the things that have been in part responsible for what we're facing. So changing up those things I think is important.
Yeah, a lot of those foods come from the poverty of our
Absolutely,
past. I mean,
absolutely, and even grocery stores. This is another thing that's a real problem. Grocery stores in communities where we live, they will have what we buy. So if we buy it, they will. It's very circuitous, but that's how it is. So if you don't demand better produce, if you don't demand better cuts of meat, if you don't demand certain things, and yes, they are inexpensive. It's hard. It can be very expensive to eat properly, but we only have one body. So, and I can't stress enough that there are ways to do it. There are ways to make substitutions and changes in the things that we feed ourselves, without sacrificing taste and without sacrificing comfort and love and tradition.
Yeah, there's one more question that I just thought of. It's been kind of brewing in my own mind here as we're talking about a lot of these problems. Is it fundamentally a racist concept that African Americans are somehow physiologically more prone to diseases, to problems? Is it possible that that's...
That's a pretty loaded question.
Well, I mean, it's been one of those things that's been brewing.
I don't think that African Americans are necessarily more susceptible to anything in this from the standpoint of cardiovascular disease than anybody else who ate the same things and lived in the same environment and it was exposed to the same kinds of things wouldn't be predisposed to. I don't think there's anything necessarily inherent about being African American or being black that means that you're more predisposed to cardiovascular disease. Again, I think it has to do with education and all the other things that we've talked about more so than there being something physiologically different.
Yeah.
You know, there are things that people of color are more susceptible to, but I don't think cardiovascular disease is necessarily one of them. I think we just have to look at it in the context of all the other things.
Yeah.
Yeah.
No, that's great because it's just people have been saying
Yeah.
that to me. That's what
Yeah.
people think. That
Yeah.
It's just
Yeah.
you know, oh sure, African Americans just have all these more physiological problems.
Right, right. No, there's nothing different about, you know, why, you know, a 30-year-old black person necessarily has a stroke. But if they are hypertensive and high cholesterol levels and, you know, family history and all those other things, yeah. So I don't know. I guess that's maybe an easy way to look at it, but I don't think it's completely accurate. So.
Great.
Well.
Terrific. Well, let me give you a time here. We're at 48:44. So I think we're all set.
Okay.